Well, good evening. My name is Larry Wolford. I'm clinical professor of oral and maxillofacial surgery, and also I'm in the Department of Orthodontics at Texas A&M University College of Dentistry, and I'm also in full-time private practice at Baylor University Medical Center in Dallas, Texas. A little bit about me. I've educated residents and fellows in oral and maxillofacial surgery for 48 years. I've co-authored 2 textbooks and co-edited 3 other books. I've written over 50 book chapters for other books. I've published over 230 scientific papers, most of those in reference to orthognathic surgery and TMJ surgery. I've received the William J. Guise Award and the W. Harry Archer Award, which are 2 of the highest awards offered in the United States in oral and maxillofacial surgery for major contributions to the specialty. I've developed the state-of-the-art surgical procedures and philosophies and evidence-based protocols for orthognathic surgery, TMJ surgery, sleep apnea. I've given hundreds of national and international lectures, and my primary expertise is in orthognathic surgery, TMJ surgery, and sleep apnea surgery. Today we're going to focus on the temporomandibular joint. In my declaration, neither I nor any member of my family have a financial arrangement or affiliation with any corporations, commercial products, or services that may be discussed in this presentation. The TMJs are the foundation for all these factors: jaw position, occlusion, facial balance, TMJ and jaw function, growth and development, airway function, comfort, and orthodontic and surgical outcome stability. TMJ pathologies can adversely affect any or all of these factors. What are the interrelationships of the TMJ and facial structures? Well, TMJ problems can coexist with dental facial deformities, independent of each other. This is important, though. TMJ pathologies are a common cause of dental facial deformities. Unfortunately, TMJ problems are commonly ignored by surgeons and orthodontists and other healthcare providers. Untreated TMJ pathologies are a very common cause of surgical relapse as well as orthodontic relapse. Treatment goals when we are dealing with patients who have jaw deformities is we want to correct the skeletal, dental, facial, TMJ, and airway problems so that we can optimize function, aesthetic, and pain outcomes. For instance, you see an 18-year-old young lady here with juvenile idiopathic arthritis. This caused significant condylar resorption with this resultant facial appearance and deformity. She's had years of orthodontics, so her occlusion does not look as severe as her jaw deformity. But if we do a cephalometric analysis, we can see that there are a number of factors that help us identify the type of deformity and will also give us good information on what we need to do to correct this particular deformity and TMJ profile. For this young girl, we're going to reconstruct her TMJ joints with a total joint prosthesis, lengthen her ramus vertically, do what we call a counterclockwise rotation of the maxillomandibular complex to give us this kind of a profile, and consequently this type of an outcome, where we can enhance the patient's beauty, facial balance, with good stability, eliminate pain issues and headaches if they exist, and importantly, establish a good, stable occlusal outcome. So when I evaluate patients, these are the things I look at: history, clinical, and then imaging. And we do cone beam imaging here, which includes lateral cephalograms, panographs, TMJ tomograms. But when working on the TMJ, one of the most important diagnostic tools we have is the MRI. So right now we're looking at a normal MRI, fossa, articular eminence in the front, ear canal is back here. Here's the condyle coming up like this. And here's the articular disc sitting right up over top at about the 12 o'clock position of the condyle. An opening. Condyle comes forward out of the fossa, and the articular disc should move forward with the condyle. That's a normal TMJ. But one of the most common issues we have is an anteriorly displaced articular disc. And this displacement of the disc, be it anterior, medial, lateral, posterior, but displacement of the articular disc is usually related to instability of the ligaments that normally keep those discs in position. Those ligaments become either stretched, torn, herniated, or degenerated. And this allows the disc to slide out of position and then renders the ligaments unsuitable for repair. Noises in the joint. When we have clicking and popping, it usually means that the disc is anteriorly displaced but reduces on opening. If we have crepitation or glitches or grinding noises in the joint, it usually means that the disc may be medially displaced, or it could be laterally displaced. Or it could mean that there's a perforation with bone and bone contact of the joint, fossa and condyle. Now, what about the silent joint, the joint that in function makes no noise? Well, it could indicate that the TMJ joint is perfectly normal. Or it could indicate that there's a displaced disc that is non-reducing. Or it could mean that this could be medial, lateral, or posteriorly displaced, but doesn't make any noises. The MRI is the best diagnostic exam that we have for TMJ pathology. So the silent joint, again, may indicate that the disc is anteriorly displaced, but as the condyle comes forward in opening, in function, the disc remains anteriorly displaced without reduction, so it doesn't make any noise. Another condition is when we have a very steep articular eminence, and the disc can be anteriorly displaced, but sitting in a vertical position here between the articular eminence and the condyle. And as the condyle opens, it immediately reduces on the disc and doesn't make any noise. Looking at a posterior view here of the condyle, the disc could be medially displaced, or it could be laterally displaced, or posteriorly displaced and not make any noise on opening. If a patient's been in long-term splint therapy or placed into devices like Herbst appliances, sometimes the bilaminar tissues here will thicken so that on opening there will be just a smooth transition onto a displaced articular disc and silent. So silent joint does not mean that it's normal, does not mean that it's healthy. Could mean that the disc just doesn't make noise. The disc does not reduce and make a sound. So when we have displaced articular disc, and here you're looking at the condyle and fossa, articular eminence, and here's the disc in this position, anteriorly displaced. And when we have this situation, and the disc is still in good condition, we can put the disc back in position with what's called the MyTech mini anchor technique, where we come in and we'll excise this bilaminar tissue here that's overlying the condyle, take the disc, mobilize it, and bring it back up into the joint on top of the condyle, as you see right here. And then we can stabilize it with this MyTech mini anchor technique. So we're looking at the condyle from a posterior view. Here's the mid-sagittal plane. Usually the MyTech anchor goes in just lateral to the mid-sagittal plane, and we start immediately, and we just do 3 throws of the double-armed MyTech anchor, the artificial ligaments. There's 2 sets of it. And one we put over towards the medial side, and then the other one we put more lateral and tie them to hold that disc back in place on top of the condyle. There are some specific criteria that I use when this MyTech anchor technique can be used with high predictability. When there is an anteriorly displaced disc, 4 years or less time since the initial disc displacement. That's critical. The disc is still salvageable, as is the condyle, with no major degenerative changes. No other joints involved. In other words, no polyarthritis. If a patient has multiple other joints that are involved that have issues, then putting the disc back in place by any means may not work well, because it means the patient probably has a systemic condition that will affect any repaired joint that the patient may have. There can be no reactive arthritis. That means no infectious aspects such as bacteria or viruses within the joint. No connective tissue autoimmune disease. This won't work in the juvenile idiopathic arthritis patient, those with psoriatic arthritis, ankylosing spondylitis, etc. All of those connective tissue autoimmune diseases, putting a disc back in place is not predictable. No intracapsular adhesions. If there's already adhesions between the disc and the fossa, disc and condyle, trying to put the disc back in place will likely not be very predictable. And importantly, no infection history. In other words, no history of sexually transmitted diseases, recurrent upper respiratory infections, recurrent urinary tract infections, genital infections, GI issues such as irritable bowel syndrome, etc. The presence of those conditions may render an outcome of putting the disc back in place as a poor outcome. So TMJ conditions that create dental facial deformities and cause orthognathic surgical relapse can be broken down into two basic types, where you have condylar pathologies that the condyle grows or enlarges, or the condyle resorbs. These are the two main categories that cause relapse in orthodontics and orthognathic surgery and can create dental facial deformities. So these are the pathologies primarily that can cause condylar growth, the most common ones: condylar hyperplasia type 1, condylar hyperplasia type 2. We're going to look at those here in just a few minutes. Then these factors here that cause condylar resorption. And again, we'll talk about each one of these independently as well. Condylar hyperplasia type 1, this is my specific classification, involves patients with mandibular prognathism. Professor Obergazer would term, in his classification, would term this as bilateral hemimandibular elongation. I like my classification system much better. But condylar hyperplasia type 1 is where there's an accelerated, prolonged growth of the normal condylar growth mechanism right here in the very top of the condyle. The onset's at puberty, when the mandible starts to really grow at an accelerated rate. When it occurs bilaterally, I call it type 1A, the most common cause of condylar hyperplasia. And if it occurs in just one joint, I call it type 1B. And it causes a worsening class 3 skeletal and occlusal relationship. As we get hyperactivity, accelerated growth in the top of the condyle here, it causes the mandible to elongate. Normal mandibular growth is about 98% complete in most females by the age of 15, in males, the age of 17 to 18 years. If a patient has this condition, condylar hyperplasia type 1, there's an accelerated growth that can continue into the early to mid-20s. So in other words, with this condition, it may not stop at the usual growth time. That's why the treatment of mandibular prognathisms has received such a bad name as far as stability in surgical treatment, because if this condition is present, it's generally unrecognized by clinicians, and it grows much longer than the normal growth phase. So normal mandibular growth during puberty, if you measure from condylon to point B, for females grows at a rate of about 1.6 millimeters per year, males 2.2 millimeters per year. With condylar hyperplasia type 1, there's an accelerated growth rate, so the mandible becomes more prognathic. So this is one of the first patients that I treated back in about 1979 when I first recognized this particular condition. You can see she's class 3. She has a class 3 occlusion. She was class 1 when she was about 12 years old and grew into a class 3. So back then I had treated a number of these cases that grew back out. So I finally figured, well, gosh, if I take out the growth center of the condyle, maybe this will stop the growth. So I started doing what I call a high condylectomy, removing the top 4 or 5 millimeters, the condyle, and remove the growth center up in here. Right there, and just take that out, put the disc back in position, and proceed on and do the orthognathic surgical procedures. You can see herself on the left-hand side. On the right-hand side, high condylectomies, put the disc back in place, double jaw orthognathic surgery, setting the mandible back a little bit with the counterclockwise rotation, advancing the maxilla some, little chin augmentation, and we end up with this kind of results. You see her on the left, pre-surgery, in the middle, 7-year follow-up, on the right-hand side, 22-year follow-up. Typical case, highly stable with this technique. Highly predictable, highly stable. And a good, stable occlusal outcome. Now, I did her surgery when she was 14, so she still had normal growth. But by removing doing the high condylectomy, it absolutely stops the growth of the mandible in an AP direction. The Wolford 1 osteotomy will stop AP growth of the maxilla, so these occlusions stay together. A study we did on this group, 54 patients divided into 2 groups. Group 1 consisted of 12 patients where I just did orthognathic surgery only. I did not treat the joints. Group 2, 42 patients, we did the orthognathic surgery plus the high condylectomies plus putting the disc back in that position. All patients in group 1 that I just did the orthognathic surgery grew back out into class 3s. All 42 patients that I did in group 2 with the high condylectomies, putting the disc back in place, and the orthognathic surgery all remained skeletal and occlusal class 1s. Condylar hyperplasia type 1B is where the growth occurs unilaterally, in this case in the left joint, pushing the mandible off to the right. Now, when you have a unilateral condylar hyperplasia, this type 1B, you also have to look at the opposite joint, because very commonly, about 2/3 of the time, the disc on the opposite side will become anteriorly displaced. This young lady had pain in her right TMJ, not in the left side. And she had headaches and significant pain. Because the mandible is growing transversely, more horizontal, you don't see the AP difference that you do in the bilateral condition. But you can see her lower dental midline shifted significantly off to the right side, getting progressively worse. Posterior crossbite on the contralateral side. The end-on incisor relationship. Ossiphometric analysis. And treated with a high condylectomy on the left side, but bilateral disc repositioning with the mytic anchors, since she had that displaced disc on the contralateral side. And then double jaw orthognathic surgery, moving the maxilla forward some, we did a sort of a counterclockwise rotation, so the mandible chin came forward a little bit also, but enables us to get this kind of result for her. And very stable outcome. Eliminated her right TMJ pain, her headaches, eliminated the pain down to her neck and shoulders, and a good stable occlusal result. If that left high condylectomy would not have been done, she would have grown predictably back into a class 3 occlusion on the involved side. She would still remain class 1 on the opposite side, but her midlines would shift off once again. Just another young lady, a 14-year-old, class 3 occlusal relationship, getting progressively worse. For cephalometric analysis and treatment plan, we did the high condylectomies, put the disc back in place, double jaw orthognathic surgery, the genioplasty, let us end up with this kind of outcome. And a good stable occlusion. If the high condylectomies would not be done in this case, her occlusion would not have remained stable. Her mandible would have predictably grown back out again. A more severe case, a 15-year-old male. You can see the severe deviation of the mandible off to the left side. He has bilateral condylar hyperplasia, type 1A. Just the right side is growing more rapidly than the left side, but the left side also is overgrowing as well. His profile and his occlusion. So here's his lower cuspid, here's his upper cuspid. Severe class 3 relationship. Cephalometric analysis. It's got a high occlusal plane angle, facial morphology, but excessive growth of the condyles, causing this accelerated growth of the mandible. Excuse me, here he is prepared for surgery. So I had the orthodontist open up space here so I could get the lower incisors out into a better position. And I'm going to do bilateral body ostectomies and remove this space on both sides, plus do sagittal splits, plus do the high condylectomies, plus do the maxilla. So high condylectomies, put the disc back in place, bilateral body ostectomies, sagittal splits, and the maxilla. This is all done in one stage. Allows us to end up with this result. Now, he did his surgery when he was 16 years old, which means he still had 1 or 2 years of normal growth, but he has this abnormal growth. Doing the high condylectomies stopped the growth. The mandible did not grow after that. Allowed us to get a stable result at the age of 16, instead of waiting until his growth would be normally complete. But his growth would have likely continued well into his mid-20s. This condition is self-limiting. It just grows for a long time. Again, I did a surgery at 16, 3 years post-surgery. He's remained very stable. The other kind of common condylar enlargement I classify as condylar hyperplasia type 2. And the most common pathology that causes enlargement of the condyle is an osteochondroma. It causes unilateral vertical elongation of the face, And it commonly, if it's growing rapidly, will cause an open bite on the ipsilateral side, and it can cause a transverse cant in the occlusal plane. Sort of see an open bite tendency over here because of the elongation. So the treatment protocol, I actually began doing this back in 1976. I do a low condylectomy, and then I just reshape the condylar neck. The condylar neck is much broader anteroposteriorly, mediolaterally than normal, and so you can just recontour it and let it function as the new condyle. And then just put it up into the fossa, put the disc back in place on that side. Then usually it's double jaw orthognathic surgery to correct the facial asymmetry, and sometimes requires excision of part of the inferior border of the mandible on the ipsilateral side to get the best symmetry. It allows us to get this kind of outcome. Again, this girl, I treated her when she was 14. Able to establish, I think, nice facial balance for her, and good occlusion and a good jaw function. Another patient with condylar hyperplasia type 2, involving the left TMJ, causing the mandible to shift off to the right side. When you have these unilateral growths like this, very commonly, the disc on the opposite side, about 2/3 of the time, the disc on the contralateral side will become anteriorly displaced because the overloading that results from the overgrowth of the contralateral condyle. On top of her condylar hyperplasia type 2, on the left side, her mandible and maxilla are also somewhat retreated. So she has an anterior open bite, and she has a posterior open bite on the left side. Now, sometimes these osteochondromas can become quite large. So there you see the outline of the socket and the articular eminence, and here's the condyle and the tumor. I think it's interesting, even with these large tumors, oftentimes the disc is in normal position. It's the contralateral side that the disc becomes displaced. So this is just her MRI. And here, you can see the articular disc is in position over the tumor. And on function, on opening, as that tumor shifts forward, the disc remains in position. So here's our cephalmetric analysis and the prediction tracing. We're going to remove the osteochondroma, reshape the condylar head and neck on the contralateral side. I'm sorry, on the ipsilateral side, and then put both discs back in position with the Mitek anchors and perform double jaw orthognathic surgery. That allows us to get this kind of a result. And importantly, a good stable occlusion. If you just do orthognathic surgery on these patients, that tumor that can continue for an indefinite time period will just create the jaw deformity once again. So this is a study we did on 37 patients with condylar hyperplasia type 2. 74% were females. Over two-thirds of the development of these tumors were between the ages of 12 to 20. The disc is commonly in place on the ipsilateral side, but almost 2/3 of the patients will have a displaced disc on the contralateral side. But with this surgical protocol that I've just showed you, the outcomes are incredibly stable and predictable. Another patient, unilateral right condylar hyperplasia, causing that side to elongate vertically. It's causing a displaced disc on the left side, with most of her pain on the left side, not on the side of the tumor. Again, this is commonly a vertical growth vector, so you don't see the development of a prognathism. This is classic for a unilateral condylar hyperplasia type 2, where you get an open bite on the involved side, the ipsilateral side. And for her, here you can see the condyle, the tumor. And importantly, her disc, my pen's not working here, but her disc is in position. And when she opens, condyle comes forward, and her disc, if you look at the bottom left-hand side there, the disc moves forward with the tumor. This is fairly common. You can see the open bite that developed, got worse during the preparation of her orthodontics until we got to surgery. So again, the surgical treatment, high condylectomy, put the disc back in place with the Mytec anchors, double jaw orthognathic surgery, remove a portion of the inferior border to get vertical symmetry on both sides. That's our self-analysis. We're going to remove about 11 millimeters once we get everything positioned from the inferior border of the mandible. Allows us to get this kind of an outcome. And importantly, a good stable occlusion. You see her initial occlusion at the top level, in the middle, just prior to surgery, with the increase of the open bite related to increased growth of the tumor, and then a good stable occlusion at 2 years post-surgery on the bottom. Now, displaced TMJ articular discs commonly coexist with dental facial deformities. So here's a lady, she's probably in her mid-30s. She's got a severely retreated mandible. Now, when you see a retreated mandible like this, there are several things that you should always look at. Number one, her occlusion. Number two, possible TMJ involvement. Number three, nasal airway obstruction related to enlarged turbinates and or nasal septal deviation. Next number, decreased oropharyngeal airway and potential sleep apnea. Here's her occlusion. You can see it's class 2. And her cephometric analysis with the anteriorly displaced disc, high occlusal plane angle. Again, high occlusal plane angle morphologies most commonly have TMJ problems and nasal airway obstruction. So you can see her condyle, you can see her disc anteriorly displaced. And again, just a quick review. Remove the bilaminar tissues here, mobilize the disc and bring it back up into the socket between the condyle, on top of the condyle, and stabilize with the Mytec anchor to keep that disc properly positioned over top of the condyle. So this is her prediction tracing. This is all done in one stage. Disc repositioning. followed by sagittal split osteotomy to advance in a counterclockwise direction, followed by the maxillary osteotomies. And while doing the maxilla, we can go in and reduce the turbinates, straighten up the septum if necessary. Her chin, with this counterclockwise rotation, came forward 20 millimeters. It allows us to get this kind of result. And on the right-hand side, you can see a 15-year post-surgical follow-up. Totally pain-free. Good jaw function. And importantly, a good stable occlusion, as you can see on the bottom. So these techniques are highly predictable when performed for the right indications and meeting the criteria I previously mentioned. This can also occur in class 3 patients. See, she's prognathic, deviated off to the opposite side, had anteriorly displaced disc bilaterally, class 3 occlusion, dental midline way over here. So she had bilateral condylar hyperplasia, worse on the right side. But she's older, she's 28 years old. Her growth would be complete. Again, this is self-limiting condylar hyperplasia type 1. So at the age of 28, her growth would be complete. So we only need to do the disc repositioning and the orthognathic surgical procedures that included setting the mandible backwards, advancing the maxilla, leveling it transversely to allow us to get this kind of an outcome. And importantly, a good stable occlusal outcome. In this situation, putting the disc back in position is incredibly important relative to her health and well-being, eliminating her headaches, her TMJ pain, her myofascial pain factors. If the discs were left out of place, just the orthognathic surgery performed, she would likely have worsening symptoms. So we did a study, looked at 70 of my patients, 120 TMJs treated with MyTech anchors, and we had a 95% success for the criteria of significant decrease in pain, size of opening greater than 35 millimeters, and a stable jaw and occlusal result. And this is particularly true if the surgery is done within 4 years of the onset of the disc displacement. But after 4 years, the success rate drops dramatically, down to maybe only 60 to 70%. Importantly, in putting the disc back in place with the MyTech anchor technique, you need to look and make sure there's no sexually transmitted diseases present, connective tissue autoimmune diseases, reactive arthritis, synovitis, and polyarthropathy. If those conditions are present, the outcomes are not very good. Here's a young man, I believe he was about, I think 17 when I treated him. You can see he's looks a little bit underdeveloped from the front. In profile, you can see that both the maxilla and mandible are retruded. He has a very short chin neckline. He's got sleep apnea issues. He has enlarged turbinates that block his airway. He's got a class 3 occlusal relationship with an anterior open bite. And he's displaced discs and a very narrow airway back here. And he's got these enlarged turbinates here that totally block his airway on both sides. The airway is a little black area here around those turbinates, which is almost totally obliterated, causing total nasal airway obstruction. He also has a deviated septum. So we treated him by putting his disc back in place. If you look on the right-hand side, advance the mandible in a counterclockwise direction, mobilize the maxilla in 3 pieces, reduces turbinates, straighten the septum up, then stabilize the 3-piece maxilla. Allow us to end up with this kind of outcome. Good looking smile, improvement in his profile, significant improvement in his airway where he can now breathe through his nose. He was always a mouth breather before. And his oropharyngeal airway has opened considerably. But also, importantly, a very stable, predictable occlusal outcome. Now, not all patients have dental facial deformities that have disc displacements. We can have TMJ disc displacements in patients who have a skeletal and occlusal class 1 relationship. So this is a 13-year-old young lady who had, by MRI, anteriorly displaced articular discs. She had severe headaches, myofascial pain, TMJ pain. She missed about 2/3 of her school days because of her pain. But she has a class 1 cuspid molar relationship. Condyle, her disc anteriorly displaced. Now, when a disc is anteriorly displaced, there's a decrease in the joint space. But yet the teeth adjust to that TMJ position. So she has a class 1 cuspid molar relationship, but she has this decreased joint space. When a disc is displaced anteriorly, it oftentimes will thicken. So when you put a thickened disc back in over top the condyle where there was a pre-existing decreased joint space, it pushes the mandible forward, creating an end-on incisor relationship and posterior open bites. So what I usually do in this condition is when I put the disc back in place, I will treat it like a small prognathism and do sagittal split osteotomies so I can maintain my occlusion. So here she is, before surgery, 1 year post-surgery, headaches, TMJ pain, myofascial pain, all eliminated. 10 years post-op on the right side, totally pain-free, no headaches, no TMJ pain, no myofascial pain. Maintaining a good profile and a good stable occlusion at 10 years post-surgery. So we know that when we put this back in place, when there's a decreased joint space, it's going to cause the mandible to become displaced forward, creating end-on incisor and posterior open bites, and can be treated by doing sagittal split osteotomies at the same time. Just another young lady, anteriorly displaced discs, headaches, see a retreated mandible, but her occlusion is pretty good. Good class 1 skeletal relationship. So I treated her by putting her disc back in place, doing the sagittal splits, and then I did a genioplasty, a chin implant, to improve her profile. So we're able to eliminate her pain, allow her to have good jaw function, eat whatever she wants, and have an improvement in her facial profile and her overall self-image. And importantly, a good stable occlusal outcome, as you see on the right-hand side.